let me ask you this, because you've been treating patients for decades. I'm in my second decade. Oh man, it's kind.
40 years.
You've been treating patients for decades, and can you summarize what were your stages, maybe like decades? Well, how is your treating at the personal level of a patient? Like for example, I think you know what I mean. What have you learned as you treat people through time that made you interact with them differently at the chair, obviously to minimize issues, to have a better relationship with the patient? What were you doing when you were 30 that then when you were 40 you learned something different and then you modified it? Describe that experience to us so that we can gain from you some insights on how to have a better relationship with patients.
Well, relative to, let's say, communicating a treatment plan to a patient, and I think all of us, when we start out, we take all these classes or maybe go to PROS or something like that. I tended to overwhelm people with knowledge earlier on, okay? Everything that I knew in my brain, probably to impress them, and all kinds of options and all kinds of potential outcomes and risk and benefits, which obviously we have to do, okay? But it was way too scientific, way too dental schoolish, way too dentalish, okay? What I found was, as over time, that I would offer listening to what they wanted, okay, what their goal was, okay? And I would offer the minimal option that would satisfy their goal and give them success. And then I would offer one other option, okay? I would ask them, would you like to know what I see, or maybe if I could wave a magic wand? That's a classic thing people would say, what would I do? And then I would offer, the textbook option, let's say. So, and I would tend to only offer two, okay? What would satisfy their goal, then also two, what would be, textbook, professor, lecture options. So that was very helpful to get people to say yes, okay, relative to communication. I'll tell you what I've gone to do over the last few years. I used to charge just a ton of money, even for exams and stuff like that. I tell you what I do now, especially for aesthetic patients, not somebody coming in just for a normal exam or something, but I give away 10, 15 minutes of free time to meet somebody, or even on Zoom, even better today, okay? Listen to what they want to do, show maybe a couple of cases, what I've done in the past that are similar to theirs, and give them a range, because I know pretty much what I'm going to charge. Give them a range of what I'm going to charge, and then let them go from there. And then I find that going to the full exam, going to the full records appointment is much easier than if I start out with a 2-3 hour exam, a bunch of records, a bunch of this, a bunch of that, for a fairly significant fee, overwhelm all of them initially when they really just wanted today a single crown or something. Okay, so that was very helpful to me. And then I wouldn't get into, just like you said to me a second ago, don't get in a bunch of material discussions with a patient. Get into, you're going to do this type of treatment, a conservative treatment. Okay? You're going to do an implant, all right? You don't have to get into types of abutments and all that. I used to do all that stuff, and that was, I thought, the right thing to do, but it turned out to be extremely counterproductive, okay? And then just let them decide. Let them, I became a lot less pushy as I've gotten more experienced over time, and find that people, if they aren't pushed too hard, they'll make the decision that is appropriate for them based on their circumstance, okay? So that would be the insight I would say about a examination process and treatment plan.
How do you calm a patient down? A patient that, you've seen it 2 or 3 times, you've done some kind of work, and then comes back for some reason and is not happy. What's your technique? Has it changed over time? What's your experience tells you?
All right. So
how do you talk to them?
I'll never forget. I'll answer that, but let me back up for something that I try to do, and I learned from a guy named Bert Press, who was the president of the ADA in 1983 when I graduated. Richard graduated too then, right around then. So anyway, anything you tell a patient later is an alibi. Anything you tell them before it happens is an explanation. Okay, So one of the things, even though I try not to give too much information, if we're doing bonding procedures, I always say occasionally some people have some sensitivity. You don't want to go down the list of every little teeny tiny thing and stuff like that. And then, the bigger issue for what I do, since I do mostly aesthetically motivated patients that come in, and I can tell you that the more aesthetically motivated patients you have, you've heard this. Everybody's heard this a million times. I'm going to beat a drum when I tell you this, that you need to start a case with a really good prototype that's very close to the final shape and final color, at least, of acrylic or PMMA or machined or printed to the final shape. If you deliver something that's significantly different in color, brighter or darker, significantly different in shape, then whatever temper you had in the mouth, you're going to be you're going to have 50% of your patients unhappy. Okay? Now, the other thing is sometimes you're going to occasionally have a patient where you pretty much do exactly what your prototype was. Basic the shape is 98% there. The color's 95% there because it's not the same as acrylic, and they're going to be a little disappointed. All right. I learned this a long time ago from a couple of very bright people. What I tend to do with patients, I say, listen, please, we cemented the case. Let's say they're sitting and something changed in their brain. Please wear this for 6 months, okay? If you wear it for 6 months, come back, and if you really, really, really hate it, I'll do it over, okay? Now, you got to be sure. I mean, if you had a crazy patient or somebody and you did everything they asked, fine, okay? You may not do that. But maybe you think in your mind, oh, you would have liked it 3% brighter or 3% longer. You're 98% there, but that last 2 or 3, 4% you didn't get. I can tell you that universally, when they leave and they start accepting that work and their friends say, hey, you got a nice smile and stuff like that, then you're not going to have to replace. Maybe 1 out of 100 you might have to replace. So that's how I would attack an unhappy patient. But have a little empathy for that, Don't be combative with them, okay? And sometimes you just got to say from as peaceful place as you can, gosh, that's the best I can do. I'm really sorry. That's the best I can do. I can't do any better than that. Sometimes, and hopefully, you're not saying that a lot. So that's how I would handle it. And then, the other side of that, every once in a while, Miguel, you have an absolute crazy that you can't make happy, just no matter what you do. And the best thing that I could recommend anybody to do, I learned this from my wife, she's a therapist and a dentist, is you just take it, okay? You stand unaffected. It's a term in psychology, is somebody's throwing shit at you, and you do your best to just take it and say, I'm sorry you don't like it. I appreciate that. I accept that you don't like it. I'm sorry, but I did what you asked, or that's the best I can do, and I'm sorry you don't like it. And that's what I would do.
Rich, we're asking questions. Go for it.
Well, I was looking at some of these questions that had come in that I saw here.
Oh, you have them. Great.
Yeah, it's so how to start learning and communicating with the lab and the ceramic and natural structures and all that. I think a lot of things with communication in dentistry, and I think this is where the students will ask me about, is the whole thing, a picture is worth 1,000 words. So when you're dealing with aesthetics and even posterior, for me, the photography is huge in the new patient experience. It's part of that thing, the whole process. And when you have that, then you have a lot of times defend yourself out of situations that are absolutely simple. And so, I think the biggest question they have is how important is photography in communication? And with that talking about defending aesthetic cases, but I will say defending posterior cases. I think, Miguel, you know this too.
I will add to this that you're right. As we give courses, a lot of our colleagues that come and take our courses, a classic question is which lab do you use? I'm looking for a good lab. And then, how do you communicate with them usually follows up. So that is a very common question. I believe that the reason that I don't have a lot of issues communicating with the laboratory is because I know what I'm talking about. And that sounds so pretentious, but it's not. I'm not saying it from a pretentious place. I'm saying once I understood materials, which is learnable, once that I understood implants, once I understood occlusion, which is learnable, you as a general dentist who is shaky on this concept, if you put 1 year, 1.5 years of your life, or even less, 6 months, and with reading and courses and papers, and you need some cases that come through your chair tube to use it. Like you can read and see all you want, but the reason I say 1.5 years is because you want enough cases also that so you can apply them and see if it's true or not. When that happens, all of a sudden communication with the lab became so easy and so frictionless, because now you can have a communication. You can't communicate to a lab what you don't know. And I think a lot of these problems with general dentists having issues with communications with the laboratory is because they don't know what to ask from the laboratory. They don't know what to tell them, what to give them, what the options are. So communication to the laboratory, to me, gets solved greatly when you know what you're talking about. And knowing what you're talking about is much more attainable than what many people think. You can take any of the 3 of us classes of dental materials, and then you want to take it twice, and then ask him a million questions later. Within 6 months, you'll know everything about dental materials. And then you want to know about occlusion, you want to know about... So once you know this, communication with the lab becomes simple. So no, I don't see many people talking about that. It's hard to communicate when you don't know what you're talking about.
Well, and we have, and the thing that's frustrating for the lab techs, it doesn't matter what level the lab is. If you will not even pick up your iPhone and give them a photo of a bicuspid, that's the number one thing I get from dentists. The lab can't, I told them A2 and they didn't get close. And I said, well, did you give them a photograph of the teeth? Even if it's an iPhone photograph, they know what their A2 looks like and they can look at your photo. Otherwise, they're just throwing it up in the air. I mean, the shape of the tooth.
Well, this is the photo that the lab gave. Look, the lab gave this.
Yeah.
Right.
Exactly.
But when the lab gets like, give me an A2, like this.
Yeah.
That's what they get. And they expect a perfect match.
So the thing is put a shade on it.
Well, we're
Just basics. So
what you're speaking to is that there's a certain, whether any process, and we're talking about shade communication, there's a certain minimum pieces of communication or tools that if you don't do, you can't be successful. Okay. And so I would recommend the answer specifically to the question. I used to, I don't that much anymore, but we've got 2 people here that are world-class educators in photography and shade communication. So the audience listening, please, Dr. Miguel teaches courses exactly in this, among many other courses. Please look at his course list. Richard, Dr. Young teaches exactly this stuff, quite frequently, actually. And speaking to Dr. Ortiz's point that you have to get the information. Now, there are several pieces that it's a skill set. It's a skill set to take a decent picture. It's a skill set to understand what's supposed to be in that image. And if you give that to a technician, that minimum set of information, that they're going to be right more than not. And the big frustration is that it's not going to happen magically. Okay, an A2 is not an A2 is not an A2. There's different.
And when you learn how to take pictures, because this is what happened. I agree with what you're saying, and thank you for the plugin. You also have courses on this, and you were probably one of the first when writing scientific papers about this. I don't like my lab. What lab do you use? And I said, well, what do you like about it? I don't know. What comes back is like, I don't like it. I put it in the mouth and I don't like it. The veneers? Yeah, I did the veneers. Look, here's the picture, so my colleague will pull it. You see, doesn't look nice. Okay. How will you improve it? What is it that you don't like? I don't know. Right?
Yeah.
So if you don't if you as a dentist don't spend the time learning shape, anatomy, line angles, smile design, and things like that, you're always going to have that problem, because communicating with the lab means I don't like it because you see what you're doing here. I would like you to do it differently. Can you do it differently? And the lab might say yes or no. And then you have an exchange. And that is communication with the lab. I actually had this 4 days ago. My brother owns a lab in Spain, Ibiza Dental Lab. This weekend I was in Spain because my mom was having surgery, long story short. I went to the lab and I was bringing cases back with me. So I opened them out, a bunch of like single unit posterior implant crowns. And the technician who I know, who's also a friend, I know him for 20 years, I said, hey, let's sit down. See this here? This doesn't look like a molar. Right? It doesn't look like a molar. You have a first molar on the posterior where your central groove is 20% to the buccal and the lingual triangular ridges occupies 80% of the occlusal table. This is not how it is. It's supposed to be inverse. You see this line angle? And that's communication. That's like, if you don't like something, and I say, look, when you do it, you see your emerging profile? I would like you to do it differently. But you can't communicate with a lab if you don't learn it first. And it is learnable. I'm not bragging about what I know. I'm actually trying to encourage people that information and knowing is not that far away. If you really go deep the first, the next year or two, you will learn most of the things that then for the next 20 years make your life so much easier. It's such a worth investment.
Well, let me summarize that, because we got the man, the myth, the legend online here, and we gotta get interviewing in with him. Yeah, well, in many different names. I'll give it a second. But so to the audience that's watching out there, okay, there are some amazing resources for you. We're talking about shade taking, shade communication. Please look at those. Then I would tell the dentist and the technician and the ceramist out there, we need to get back to the point of you're a team, okay? Just like your periodontist is a member of your team, your implant surgeon may be the same person, your hygienist, and I would take classes together. Go to a class from Dr. Miguel. Go to a class from Dr. Young. Go to a class from the digital MacGyver we got on here as a team, and learn those techniques as a team. And trust me, after you do just one course together and follow a couple of the techniques, could be from Matisse, Marwat, as I believe, could be from Sasha Hine. The name of the program escapes me right now. Somebody help me.
Bioemulation?
Yeah, the name of the product. It's.
And now you may be blank on it. I got a card here.
Yeah, it'll come back to me. Okay, and do that. All right, so let's move on here.